Thank you for this talk. So I will be talking on role of VEGF inhibitor in NSCLC, and I will briefly overview the role of these drugs in non-small cell lung cancer. So as we all know that apart from those patients who cannot afford immunotherapeutic drugs, we still don't have any option for those patients who doesn't have any actionable mutation. There is limited benefit in stage 4 non-small cell lung cancer with only chemotherapy. So there is these VEGF. What is this VEGF? So tumor and normal cell release a protein called VEGF, which stimulates the growth of new blood vessels, a process called angiogenesis. And these new vessels feed the growth of the tumor. They also provide a highway for tumor cells to spread to other parts of the body. So it is VEGF is a key mediator of angiogenesis, and it affects survival, proliferation, as well as migration through the route of angiogenesis. So studies have shown that the targeting VEGF protein may interfere with the tumor's ability to grow and spread. So right now we have two drugs that are being used in lung cancer, that is bevacizumab and ramucirumab. So these are the indications that I can get for VEGF inhibitor. First, in first line setting where there is no actionable mutation positive non-small cell lung cancer, we can combine bevacizumab with pemetrexed and carboplatin or paclitaxel plus carboplatin. And in second line non-small cell lung cancer, we can use ramucirumab along with docetaxel. Or right now there is a phase 2 study of ramucirumab plus pembrolizumab in post first line immune checkpoint inhibitor. We can use this combination. The other indication is first line EGFR mutation positive metastatic non-small cell lung cancer, where we can combine erlotinib plus bevacizumab and erlotinib plus ramucirumab. So I will briefly overview what are the studies that are there for all these indications. So this is the proposed treatment algorithm for non-small cell lung cancer with no actionable mutation positive. Those who are with poor PS, we either give single agent or combination chemotherapy or immunotherapeutic drug. Those who are having good performance status and non-squamous histology, we can give pemetrexed carboplatin along with bevacizumab plus or minus pembrolizumab if patient is affording. So in this patient, we can combine bevacizumab. So coming to bevacizumab, it is humanized to avoid immunogenicity. It is 93% humor. So bevacizumab, this is the phase 3 study of bevacizumab, where it was compared in a randomized patient between paclicarbo plus bev versus bevacizumab plus paclicarbo. The dose used were 15 mg per kg. And here they have seen that there was slight improvement in median overall survival from 10.3 to 12.3 months. The hazard ratio of 0.79, and it was found to be statistically significant. The secondary endpoints were also better, like PFS and objective response rate was increased in the bevacizumab group with 35% versus 15%, and PFS was 6.2 months versus 4.5 months. Coming to the toxicity of bevacizumab in this phase 3 trial, so there was increased risk of severe or fatal hemorrhage, 1.1% versus 4.7%. The pulmonary hemorrhage risk was slightly increased, 0.5 to 2.3. And hypertension was more seen in this patient, around 7% of the patient. The febrile neutropenia and severe proteinuria, these were the main side effect. Although you can see the percentage of the patient having such kind of severe effects was less than around 5% only. So the bevacizumab combination regimen was found to improve progression-free survival, 3 months versus 4.8 months. 6-month overall survival from 62.4% versus 72%, and the CRPR rates were also improved. The drug discontinuation and all those toxicity were quite comparable. Now the second line indication for the another drug, that is ramucirumab plus docetaxel, is also there. In the REVEL trial, they have seen that median progression-free survival was 4.5 months in those group who have received ramucirumab along with docetaxel versus just 3 months in those patients who have received single-agent docetaxel. The median overall survival was also slightly better, 10.5 months versus 9.1 months. So as you can see in this graph that there was slight improvement in overall survival probability from 9.1 months versus 10.5 months. And there was 43% of the patients survived 1 year or longer with ramucirumab. Now, this is the recent study published in 2022. Here they have compared the standard of care in those patients who was treated previously with immunotherapy, and they have either used investigator's choice in one arm, docetaxel, gemcitabine, pemetrexed, all combination, all cytotoxic chemotherapy, or they have combined ramucirumab plus pembrolizumab. So they have continued pembrolizumab in those who have previously received immunotherapy. And they have seen that overall survival was significantly improved with ramucirumab, pembrolizumab versus just cytotoxic chemotherapy. It was 14.5 months versus 11.6 months. As you can see in the graph, that it is separating right from the start that the ramucirumab pembrolizumab arm has done better, 14.5 versus 11.6 months. The hazard ratio was 0.69, and it was statistically significant. The progression-free survival was also numerically comparable, 4.5 months versus 5.2 months. In all the subgroups, as you can see, whether it is mixed, non-squamous, previous IO plus chemotherapy combination, or a sequential chemotherapy followed by immune checkpoint, in all the subgroups, it has benefited. Ramucirumab plus pembrolizumab arm was favored in this study. Next, the other indication for these drugs comes in those patients who have EGFR mutation positive. So right now for EGFR mutation positive, we have various EGFR inhibitors, where osimertinib, which is a third generation, is right now the preferred drug. The other combination that are being explored is erlotinib plus bevacizumab and erlotinib plus ramucirumab. And there are other second generation drugs also. So here we will be talking about VEGF inhibitors, the role of them. So first coming to ramucirumab plus erlotinib, in the RELAY trial, here they have seen that progression-free survival was significantly longer in ramucirumab plus erlotinib, 19.4 months versus 12.4 months. The stratified hazard ratio was 0.59. So it was significantly better. And in those patients who have especially exon 21 L858R mutation, has greatly benefited. And this combination has till date shown to have maximum progression-free survival in the L858R mutation positive patient, even better than osimertinib. So here you can see the 1-year PFS rate for 70.4% versus just 46.4% in the erlotinib alone on. So this combination has done well in this patient. The other VEGF combination that was being used was bevacizumab plus erlotinib in NEJ026 study, and this trials further follow-up study has just came, and previously it has shown to have a similar kind of progression-free survival benefit. But the recent overall survival data has shown that the addition of bevacizumab to erlotinib has not prolonged the survival in patients with metastatic EGFR mutant NSCLC. But in this study, they have seen very long overall survival, 46.2 months in the erlotinib arm and 50.7 months in the bevacizumab arm. So although in the previous study also, although they have got a good progression-free survival, but still we have to wait for longer OS data to use these drugs in a very confirmed fashion. So right now, again, I will summarize. These are the indication of VEGF inhibitors where we can use these drugs. First line with no actionable mutation positive NSCLC with pemetrexed carboplatin, plus pembrolizumab plus bevacizumab, you can use this drug. The other combination that you can use along with atezo plus bev, the second line non-small cell lung cancer, you can use ramucirumab plus docetaxel or ramucirumab plus pembrolizumab in those who have previously refused immune checkpoint inhibitor. And first line EGFR mutation positive metastatic NSCLC, I will prefer more of ramucirumab rather than bevacizumab, considering the overall survival data of bevacizumab has not fared well. But still, I will comment on this, that these drugs are not found to have that much promising till date, and there are some limited kind of indications where I use it. I mostly use these drugs in those patients who have significant pleural effusion and I want a definite response rate because patient is symptomatic. So as we have seen in these studies that those patients who have received these drugs have better response rate. So in those patients where you need a better response rate, it is better we use this drug. Thank you. Thank you very much.